classes. And as you all know, we are currently in the Cataract module of iFocus Online. And this is the 8th episode of Cataract session with the 394 episode going on for the iFocus Online classes. And I would like to welcome our chairperson, Dr. Mukesh Sharma sir, and our speaker, Dr. Subhrangshu Sengupta, who's currently working in Center for Sight Eye Hospital and will be talking today on intraocular lens, materials, constructions, types, and specific indications. To introduce our speaker, Dr. Subhrangshu Sengupta has done his MBBS from Medical College, Kolkata. Subsequently, he pursued ophthalmology from RIO Kolkata, did an FRCS Glasgow, and also PhD in ophthalmology. He has done his fellowship in medical retina and lasers and is currently working as a senior consultant in phaco-refractive and medical retina services at Center for Sight Eye Hospital in Kolkata itself. He is a recipient of multiple awards at the national conferences and has publications in peer-reviewed journals and co-authored various book chapters. We welcome Dr. Subhrangshu Sengupta for this interesting class on IOLs, which is the core for every cataract surgery. We are implanting IOLs day in and day out, and hence it is very important that we have precise knowledge about these lenses. Dr. Subhrangshu, over to you, sir.
Yeah. So I would also like to interrupt Dr. Subhrangshu here for a minute. So as Dr. Yeah. So am I audible?
A very good evening. A very good evening, all.
Yes, Subhrangshu sir, you can start the screen share. In the meanwhile, Dr. Mukesh, sir, you want to say something?
Yeah. So
Yes,
I was just trying to say that as Dr. Pranita has said just now, so implanting IOL is another thing, but knowing about IOL is very important, because what happens is that most of us in our later life, we are dependent on medical representative and the IOL company people to know about the various plus and minus about the various IOLs. Now, what happens is that every company person comes and they tell about positive things about their IOL and negative things about other company IOL. But we should have a rational outlook about every IOL, and we should be knowing everything, why there is glistening with some of IOLs, why there is some cutting of light with the IOL, what is the role of various refractive indices with the IOL. So I think this will be a very important topic for our postgraduates and also for everyone who's keen about knowing these things. So with this, I think I welcome Dr. Subhrangshu, and let's hear him about IOL material and types.
Thank you, sir. Am I audible and is my screen visible?
Yes,
Yeah.
we can hear you, and the screen is also very well visible.
So at the outset, I'd like to thank the coordinators for the cataract module, Professor Maipal Sachdev, Dr. Ritika Sachdev, and Dr. Tulika Chauhan, as well as the CFS Education Director, Dr. Santosh Honawar, for having me to speak in this iFocus Online. I'll be speaking on intraocular lens materials, construction, types, and specific indications, and I have no financial interest in any of the products discussed. So let's start from the very beginning. So the history of intraocular lenses. There was one gentleman, Mr. Tadini, an Italian ophthalmologist living in the second half of the 18th century, who performed eye operations in many places throughout Europe and documented by his advertisements in newspapers of those times. Then there was Mr. Casanova, an Italian writer and adventurer from the Republic of Venice. Tadini presented a box before Casanova containing highly polished tiny crystal lenses, which he claimed he could insert under the cornea to replace the eye's natural lens. Casanova's autobiography contains an account of the very first known idea of intraocular lens implantation. And in 1795, one Mr. Johann Casamata, he implanted the very first IOL made of glass, but the IOL dropped in the eye due to its weight. The real beginning of usable IOL technology occurred during World War II. It was Sir Harold Ridley, who was an on-duty eye surgeon who cared for crashed pilots, and he observed that small pieces of cupolas, which are nothing but PMMA from crashed planes that penetrated the eye during the crash, did not cause any inflammatory reaction. He recognized that this material could be used for artificial lenses after removal of natural lens during cataract surgery. In 1940s, he met clandestinely with John Pike of Rayner in London, sometimes in his own Bentley, to discuss the design of the world's very first IOL. They used ICI's Transpex 1, a high-quality version of PMMA, to produce the first IOL, which weighed about 138 milligram. On November 29, 1949, Ridley inserted the first lens into a 42-year-old woman after an ECC. Actually, the surgery was done in two steps. First, the ECC, and the implantation actually happened 3 months later in 1950 February. Post-op, there was high myopia. Ridley implanted the original PMMA lens in 750 patients in the next 10 years or so. Of course, there were many complications: hyphema, downward decentration, iris atrophy, glaucoma, anterior and posterior dislocation, and inflammation was quite common, and approximately 15% of these implants were eventually removed. Now coming to IOL materials and the properties. So we look at a few important properties that we come across when we are reading about any intraocular lens. What is the Abbe number? It is the measure of an optical material's chromatic dispersion, with higher values representing lower chromatic dispersion and hence better optical quality. As the refractive index increases, the Abbe number actually decreases. The Abbe number of the natural crystalline lens is 47. Then biocompatibility. That is the capability of an implanted IOL material to remain optically function in vivo without causing significant adverse responses. And we look at two types. One is the capsular biocompatibility, that is determined by direct contact of the IOL with the remnant LECs, and of course, the UVL biocompatibility. Then we look at hydrophobicity. An IOL material surface may be hydrophilic or hydrophobic. The contact angle measures the degree between the material surface and water droplet surface. Obviously, large contact angles define hydrophobic materials, whereas small angles define hydrophilic materials. Hygroscopy of IOLs is the ability of a material to absorb water and hold water. Increasing an IOL material's hygroscopy reduces the common post-operative appearance of glistenings. Then there's something called glass transition temperature. The glass transition temperature of a polymer is the temperature at which the polymer changes from a rigid, solid, glassy fluid to a softer, rubber-like fluid. For all practical point of view, any IOL that has a high value of glass transition temperature means that the IOL must be warmed up to avoid damage to the IOL during loading and implantation. Then, of course, the refractive index. The refractive index of the natural crystalline lens is 1.4. The refractive index increases with the addition of halogens, aromatic groups, sulfur. There's an inverse relationship that exists between refractive index and the IOL thickness. So with this background, we come to the various materials that are usually used for intraocular lenses. As far as the optic materials are concerned, we have the rigid material, the polymethyl methacrylate. For foldable IOLs, we have silicone hydrophobic acrylic and the hydrophilic acrylic material. Then we have rollable or ultra-thin IOLs made of hydrogel. We have Colamar material as well. For haptics, substances like PMMA, polyimide, and polyvinyl fluoride, which is called PVDF, is used. Now coming to the various materials, PMMA, or polymethyl methacrylate. PMMA, the first IOL material implanted in a human by Sir Harold Ridley in 1949, is known for its excellent tissue tolerance, long-term stability, and reduced cost. It is, as we have discussed, non-foldable, rigid, hydrophobic, and is available in one-piece version as well as three-piece version, that is lathe cut from PMMA buttons or rods. It's a reasonable material for rigid IOLs because of its high quality hydrophobic surface, excellent transmissibility of light, and the possibility to add an UV absorber to the monomers. Now, what are the concerns? So a PMMA IOL being rigid, it will definitely require a larger incision for implantation. Its hydrophobicity may be damaging to corneal endothelium during implantation, secondary to adherence of these cells during implantation. And PMMA and hydrogel IOLs are associated with higher rates of PCO compared to hydrophilic acrylic and silicone IOLs. However, a squared posterior edge optic will definitely reduce this incidence. Now we come to what is called snowflake degeneration of PMMA IOLs. It is a slowly progressive opacification of PMMA IOLs which may occur 10 years or later after implantation. These are nothing but crystalline deposits observed within the optic of the IOL. Lesions in the snowflake are dry and they should be clinically differentiated from glistenings, which are fluid-filled vacuoles and generally associated with the hydrophobic acrylic IOLs. Now, it is postulated that prolonged exposure to UV irradiation may have initiated the slow destruction of PMMA IOL material and leading to these snowflake degenerations. So there are two observations which support this. One is aggregation of opacities, mainly in the central optic extending peripherally, but keeping the actual rim free of opacities. And the anterior third of the IOL optic, which is the first to receive UV radiation, presents with more intense lesions. Of course, there are many manufacturing processes which might also lead to this snowflake degeneration. However, what is to be remembered is that these IOLs have to be explanted only if there is a significant drop in best corrected visual acuity and or there are significant visual complaints like dysphotopsia, the incidence of which is not too high actually. So PMMA IOLs are usually used in ECC or SICS cases. They can be used for scleral sutured IOLs for instances when capsular implantation is not feasible. Coming to the silicone IOLs. Silicone is a synthetic polymer constructed as an organic polysiloxane molecule. The first generation silicone materials had methyl side chains, whereas the second generation ones, they have methyl side chains replaced with the vinyl groups. Silicone IOLs have the desirable property of flexibility, biocompatibility, autoclavability, and relative inertness and chemical stability. They are made up of plate haptics or modified C-loop haptics. Although plate haptics have lower PCO and CME rates, adequate anterior capsular rim support is required to prevent decentration. Since silicone lenses have a refractive index of about 1.43, which is lower than acrylic lenses, they are therefore thicker for the same refractive power, and this thickness may require a larger incision for implantation. Silicone IOLs are susceptible to adherence of bacterial cells and silicone oil. Hence, they are at increased risk of endophthalmitis capsular opacification. Anterior capsular rim does opacify more quickly, and silicone IOLs lead to premature, uncontrolled opening of the anterior chamber, and most importantly, they may fog with condensation during subsequent vitrectomies and therefore should be used with caution in diabetic eyes or high myopic eyes. They have a lower threshold for YAG laser damage. There might be deposition of calcium oxalate on the silicone IOLs in eyes with asteroid hyalosis following YAG capsulotomy. And adhesiveness is a property by which the IOL fuses with the anterior and the posterior capsule and hence reduces the risk of decentration. Silicone IOLs have poor adhesive property and it is kept in place by virtue of its haptic and capsule coalescence. Advantages are review articles have demonstrated that silicone IOLs have lower PCO and therefore capsulotomy rate than hydrophilic acrylic IOLs at long-term use following implantation. Secondly, lenses made of some of the latest silicon materials have been associated with no more inflammation than hydrophobic IOLs. And most likely due to a lower refractive index, silicon IOLs seem to be more forgiving of the pseudophakic dysphotopsias than many acrylic IOLs. Now coming to the acrylic IOLs, they were introduced towards the end of 1980s, and they are less elastic than silicone, and therefore they will take about 3 seconds to 5 seconds to fully unfold, making them safer during surgery. They can be hydrophobic or hydrophilic. Hydrophobic IOLs have water content of about 0.5 to 1%. Hydrophilic ones have a water content of 18 to 38%. So coming to the hydrophilic acrylic IOLs, they have a higher water content, leading to superior biocompatibility with lower rates of glare, a lower refractive index, and an increased IOL thickness. They're usually single-piece IOLs. They are easier to handle, and they are less susceptible to YAG laser damage. Hydrophilic IOLs can be adapted to smaller surgical incisions by dehydration, and thus they are ideal for MICS. They are in good compatibility with biological tissues due to the high water content, and therefore they are reported to be less prone to aggregation of inflammatory cells on the surface, but they have a higher probability of PCO. Calcification has been reported likely to occur in hypertonic hydrophilic surface, which allows intraocular metabolites to enter, and the high water content can also limit the shape design of this kind of IOLs. Coming to the hydrophobic acrylic IOLs. They were introduced in 1993, and they are actually the most widely used IOL material currently. The angle of contact with water is 73 degrees. They can be in single or three-piece design. They can be folded and implanted through small incisions while maintaining their original shape. Long-term studies have demonstrated that hydrophobic acrylic IOLs have lower incidences of PCO. This may be due to the tendency of hydrophobic acrylic IOLs to adhere to the posterior lens capsule through fibronectin bindings, leading to decreased space for lens epithelial cell migration to occur in between the IOL and the posterior capsule. Furthermore, a sharp edge design is more feasible to implement on hydrophobic IOLs. The main drawback of hydrophobic IOLs is glare caused by a higher refractive index, and glistenings were also found to be more likely in hydrophobic IOLs. It is because that water that collects in hydrophobic polymers form pockets that grow as temperature changes. Therefore, properly increasing the water content of the material can be a solution to the problem. So these are what we call the glistenings in hydrophobic IOLs. The Miata scale is the one which is most widely used based on CITLAM examination findings. But nowadays, various other scales based on skin-flux imaging, anterior segment OCT, they are also coming up. Now coming to a PHS copolymer. There have been efforts to maximize the balance in incorporating both hydrophilic and hydrophobic materials to further advance IOL material configuration. One of Bose lenses is composed of a copolymer of 40% hydrophobic material, 30% hydrophilic HEMA, 26% styrene to add bulk, and 4% of ethylene glycol dimethacrylate for structural integrity. So the main composition of this IOL is a hydrophobic IOL material with significant hydrophilic content that holds a hardness of about 1.8 megapascals and a hygroscopy of 4%, and they have a lower incidence of very few reports of glistenings. Coming to colamers. Collamer, it is a biocompatible material of polymer and collagen with the purpose of making the lens lighter. This patented material is made up of 60% of polyhema, 36% of water, and benzophenone UV blocker, and 0.2% of porcine collagen. Collamer IOLs are widely used foldable IOLs designed for placement in the posterior chamber as a phakic IOL. So this table, there are two tables which actually summarize all the properties that we have discussed, which can be studied later by the PG students. We have discussed most of these points. Now coming to just a brief slide on the manufacturing process of IOLs. The main manufacturing methods for flexible foldable IOLs are injection molding and single diamond cutting or turning, can be lathe cutting and tumble polishing. Now coming to the IOLs across generations. Evolution of IOLs has occurred across generations, and we have now 7 to 8 generations of IOLs. The first generation IOLs were the ones which were biconvex PMMA PC IOL. The second generation IOLs, now see from posterior chamber, the subsequent 2-3 generations concentrated on placing the IOLs in the anterior chamber. So the second generation IOLs from 1952 to 62 were actually rigid and semi-rigid anterior chamber IOLs. Baron in France is generally credited as being the first designer and implanter of an anterior chamber IOL in 1952. Of course, advantage was less decentration with decreased reaction, but disadvantages were many, like endothelial atrophy, corneal decompensation, PBK, and instances of the UGH syndrome. So these are a few of the early anterior chamber IOLs, the rigid or semi-rigid ones, as well as some of the flexible ones. These are, like, for example, this is the Barracker open loop AC IOL. Then these are all examples of various early anterior chamber IOLs. This is the Danhem AC IOL. The third generation IOLs, where away from the angle structures, the rate of dislocation was less and there was less contact with the endothelium. But of course, there were disadvantages. More of iris chafing, pupillary distortion, transillumination defects, chances of chronic inflammation and CME, distortion and pupillary dilatation were more. So these are a few of the examples of the iris supported lenses. Like, for example, this is Epstein's collar stud lens, then the Maltese cross lens. Then we must mention about one Dr. Cornelius Bunkhorst, who developed this iris-cape lenses, the 4-loop ones in 1957, and then he thought of iridocapsular fixation, and he introduced 2-loop iris-supported lenses, which is believed to be forerunner to the capsular sac or in-the-back fixation of the modern PC IOLs. Then Fyodorov came up with his modification of the Benkhorst lenses. The Fyodorov 2 of the Sputnik lenses were quite popular in those times. Then, of course, there was the Medallion IOL late 1970s. There was the Singh with the intermediate AC IOLs. Improved manufacturing techniques led to this betterment of the AC IOLs. So they were flexible loops with multiple points of fixation. They were more stable, and the fixation elements were either spatula-like foot plates or smaller diameter lens loops, which could be closed or open. So they were more stable, design was better, less complications. But of course, we must remember anterior chamber is still not the physiological site for IOL. So these are the various 4th generation IOL models that were in vogue. Now, 5th generation, we have once again come back to the posterior chamber. So John Piercy of England implanted the first uniplanar posterior chamber lens. Then Stephen Shearing of Las Vegas, he had a major breakthrough in early 1977 with his posterior chamber IOL. And William Simcoe, he introduced his C-loop posterior chamber lens after Shearing's J-loop design. So these are various of the PC IOLs. Then we come to the 6th generation. 6th generation includes the modern lenses, the rigid PMMA ones, chamber lenses. So these are a few of the pictures. So advantages of in the back placement of IOLs, obviously, proper anatomical site, minimal magnification of less than 2%, low incidence of lens decentration and dislocation, and maximal distance from the posterior iris pigment epithelium, iris root, and ciliary processes, hence lesser chances of inflammation. Generation 7 is usually referred to as the multifocal IOLs, whereas generation 8, we refer to the accommodative IOLs and the phakic refractive IOLs. So summarizing briefly the journey of IOLs, the first foldable IOLs were developed in the 1950s. Late 1960s, phacoemulsification was introduced, and there were further advances in microsurgery as well. The very first foldable IOL was used in vivo in 1976. The first foldable silicone IOL was implanted in the human eyes in 1978. Then in 1979 came the use of OVDs, and in 1989 October, the first silicone IOL which is suitable for mass production was implanted, a 3-piece IOL. Further advancements in the early 1990s, we all know that Gimbel and Newhan, they came up with the continuous tear capsulotomy, which led to better IOL stability and centration. Hydrodissection was also subsequently introduced, and in 1981, US FDA approved IOL implantation following cataract surgery, and in 1997, FDA approved multifocal IOLs as well. So now coming to the various intraocular lens, common intraocular lens designs. IOLs can be single-piece IOLs, then multi-piece IOLs comprising of an optic and haptics. IOLs can have a plate haptic or open loop haptic, could be a C-loop haptic or a J-loop haptic. Then the haptics could be planar or they could be angulated. And then there are various modifications of the edge design as well as the optic design. Like, for example, angulated haptics, they allow for adequate pupillary clearance and addition to the posterior capsule. Now, common IOLs, now coming to the briefly to the shape of IOLs. Now, commonly biconvex IOLs are the most commonest. Most IOL calculation methods assume the use of biconvex IOLs. Dioptric power is split between the anterior and posterior optic surfaces. The anterior power is kept relatively stable, constant for most power range, while the posterior surface changes to adjust the overall dioptric power. If we look at the plano-convex IOLs, they have an advantage in eyes with silicone oil because of the flat posterior surface will limit the refractive surprise when it is against silicone oil in the vitreous cavity, and these are typically PMMA lenses. Then we also have meniscus lenses. They are required when the IOL power is very low or even negative, and the A constants are very different. Of course, all new calculators like Barrett Universal 2, they will take all these shapes into consideration when giving you the final dioptric power. A little point about IOL edge design. So square edge design and is modified to this opti-edge design. Here we see the rounded anterior edge scatters light, which can reduce internal reflections. The sloping side edge minimizes the potential for glare, and the squared posterior edge facilitates 360 degrees capsular contact and therefore reduces the chance of posterior capsular opacification. A little bit about the haptic design. You could have a plate haptic, you could have loop haptic, C-loop, J-loop, modified C-loop, and so on. Now, a little bit about the aspheric IOLs as well. Now, we all know human eye has aspheric optics. Cornea has positive spherical aberration, whereas the young crystalline lens have negative spherical aberration. With age, the spherical aberration of the lens becomes more and more positive. So now if we look at this particular graph, the spherical aberration of the cornea obviously is remaining constant, whereas that of the natural crystalline lenses becomes more and more positive with age. So what happens is that if we implant pseudophakia with a standard IOL, we are actually increasing the positive aberration all more. So conventional IOLs increase the spherical aberration of the eye, and to overcome this, there were two strategies. One, lenses with negative spherical aberrations to balance the normally positive corneal spherical aberration, and strategy two, lenses with minimal spherical aberrations where no additional spherical aberration is added to the already existing corneal spherical aberrations. And hence came the concept of the aspheric IOLs for producing sharper images. There are many aspheric IOLs. Some have anterior prolate surface like the Technis IOLs. Some have posterior prolate surface like the Acrysoph lenses. And both anterior and posterior prolate surfaces are there in the Acryos Bosch-Lomb IOLs. So aspheric IOLs have better contrast sensitivity, better mesopic vision, aid in nighttime driving, and they are definitely better options for the younger patients. But of course, they need perfect centration. Decentered aspheric IOLs can induce coma. They decrease the depth perception. They are more expensive. They need corneal topography for optimal results, and not much difference in photopic conditions and in the older age group. Now, some lenses have the property of UV absorption with the help of some additive material which chemically bind to the already existing IOL material. And then there are some blue light filtering chromophores also, which basically potential side effects. Some hydrophobic acrylic lenses incorporate blue light filtering chromophores. They protect lipofuscin-containing retinal pigment epithelial cells from blue light damage, and they reduce the risk of development or progression of macular degeneration. But potential side effect is constantly filtering. Blue light may include negative impacts on color vision, night vision, sleep, and circadian rhythms. Now, premium IOLs are multifocal, accommodative, and toric IOLs. I'll not be discussing about them because they will be taken up, I think, in the very next class. Then there are the rollable IOLs, which are ultra thin, less than 100 micron thickness IOLs, which are essentially hydrophilic materials with a curved front surface and the back surface with a series of steps with concentric rings, and they are implanted by the once popular phaconet techniques. Now, IOL implantation in a few special situations, like, for example, we have already discussed when there is absence of capsular support, scleral fixation, lenses, which are usually made up of PMMA, can be used. Iris fixated IOLs, AC IOLs can be used. Now, from the vitreoretinal point of view, silicone materials, they usually are to be avoided in cases which might require future VR intervention, because they're more likely to exhibit fogging during fluid air exchange. They are more likely to exhibit clinically significant silicone oil attachment, and they may exhibit calcification on the posterior optic surface in eyes with asteroid hyalosis. The problem with hydrophilic acrylic lenses with VR surgery include they may exhibit localized calcification on the anterior optic surface, whereas hydrophobic acrylics can exhibit glistenings. And of course, this is just a flowchart when a patient who is planning for a secondary IOL implantation, if the anterior capsule is intact, then he might, if the anterior capsule is intact and there is adequate capsular support, then he might go for an in-the-back implantation. If the capsular support is not adequate, then he might have to go for a 3-piece IOLs. However, if the anterior capsule is not intact, there is sufficient iris tissue, he might go for an iris fixated IOL. But if the iris tissue is damaged, then of course, we will have to look at scleral fixation IOLs. A little bit about the aniridia IOLs. They have this central clear optic and a surrounded colored diaphragm. They are larger sized IOLs, and they are not used too much nowadays because of enhanced techniques of pupilloplasty that are available with us. And a few points about the phakic IOLs. Implantation of IOL without removing the natural crystalline lens. Advantage being it preserves natural accommodation, mostly used in myopic eyes, can also be used in hyperopic eyes as well. They can be posterior chamber iris fixated or angle fixated. Posterior chamber IOLs, the ones that we have discussed, are the implantable Colomar lenses or phakic refractive lenses from Millennium, or sticky lenses that were made with silicone. Complications, of course, prevention of free passage of aqueous was one of the most important complications that initial models faced. PI had to be done in those cases. Nowadays, ICLs have improved a lot. There are holes in the optics which allow free flow of the aqueous. Now, iris fixated phakic IOLs, very size and the artisan ones made of PMMA, as we have discussed these lenses. Now, angle fixated phakic IOLs, there were two types actually, 4-point fixations and 3-point fixation IOLs were there. So of course, complications were similar to any AC lens. Now coming to piggyback lenses, piggyback techniques was first described in 1993. And in a case of cataract with microphthalmos, in which the calculated IOL power was 46 diopter. So presently it is used to correct post-op refractive surprises in select cases. And usually when we are doing piggyback lenses, of course, the first IOL is placed in the capsular bag and the second IOL is placed either in the bag or sulcus, but the material should be different from the first IOL, and they usually give a good depth of focus. Complications, and of course, when we are doing piggyback IOLs, complications owing to IOL removal, they can be avoided. So primary pseudophakia for managing post-op refractive surprises, usually done 4 to 6 weeks after, in cases like, for example, RKIs where explanting a lens would be difficult and so on. So there are quite a few piggyback lenses that are in use. One is, of course, the Sulcoflex, the add-on, and the first add-on. These are very of the few commonly used secondary piggyback IOLs. And complications, of course, are there. Like, for example, there might be interpseudophacous electronic pearls, what we call the red rock syndrome. There might be post-operative pigment dispersion syndrome, secondary angle closure glaucoma, UGH, etc. Now, I'll just conclude my presentation with a few slides on the way forward. So, of course, there are newer optic materials, like, for example, we are looking at injectable IOLs, shape memory IOLs, light adjustable IOLs, and some surface modifications like anti-inflammatory substances, then modifications which will actually inhibit PCO, anti-endophthalmitis, and then also IOLs carrying monitor sensors. So recent advances, the light adjustable IOLs, basically they are based on the principles of photochemistry and diffusion. Silicon lenses with CPMMA haptics, they are photosensitive to the near ultraviolet wavelength. Final irradiation step locks the power change. So basically, roughly what was done was when we needed to do a hyperopic correction, then irradiation was done in the central part. For myopic correction, irradiation was done in the peripheral part to change the radius of curvature and hence to change the power. Implantable miniature telescopic lenses were also developed. Then the telescopic IOLs, which had used mirrors for magnification, 25 times magnification. These are all basically, I've included these slides because of, for mainly from the theoretical point of view. From the practical point of view, these usually are not available in our day-to-day practice. Of course, we also had injectable intraocular lenses at some point of time. The whole idea was the ideal injectable IOL is in a liquid state during implantation procedure, and subsequently it forms a solid, a stable solid, and the process of turning the liquid material into solid in vivo has to involve some sort of external stimulation. So liquid materials were derivatives of silicon and hydrogels. Hardening methods include light, heat, enzymatic reaction. But we have to remember also inappropriate external stimuli can also cause indeterminate damage to the eye tissue. Hence, these need to be developed quite a bit. Then also there were shape memory IOLs were developed. Now I have just included 2 or 3 slides wherein I have a few studies have been shown which looked at surface modification by various materials, like for example heparin, like for example polyethylene glycol, and so on and so forth. These are all mainly from the theoretical point of view. Studies on surface modification for reducing inflammation, then a few studies on surface modification for reducing PCO, and a few studies on surface modification for reducing endophthalmitis. So I will just conclude by recapitulating the first in the IOLs. So we have traveled a long way, and of course, there's a long path in front of us. We start from 1949 when there was the first PMMA IOL implantation. In 1978, there was the first foldable IOL was implanted. 1998, Star came up with the first toric IOL. 1998, first presbyopia correcting or multifocal IOL. 2003, first accommodating IOL. 2005 came the first diffractive multifocal IOL. 2014, the first EDOF IOL. Then in 2017, the light adjustable lenses, and so on. So that's a long way and a long way to go yet. Thank you all for your patient listening. And I know I have rushed through a few slides, but I've actually tried to include a lot of matter in the slides so that the PGs can go back to the slide when they are preparing any theory questions, because this part will probably have more of theory questions at the postgraduate level. Thank you.
Thank you, Subhrangshu sir. I think that was an extensive class on a very basic topic, but that requires a lot of theory to cover up the entire subject. And you have beautifully highlighted that we are in the Diamond Jubilee year of IOL implantations, and hence we should be very well aware of everything that's in and out about this subject. So, Dr. Mukesh sir, you would like to comment upon?
Yeah, actually, very nice talk, very comprehensive one. Dr. Subhrangshu has covered too many things actually in a very small period of time. Only thing I think I would like to highlight here, and I would like him also to comment upon, is the practical correlation of the theoretical part, which he has just now enumerated. And what I mean by practical correlation is that certain advantages and disadvantages based on the physical property of IOL, and see, when we talk about PMMA IOLs, now we all know about the disadvantage of PMMA IOL is that it cannot be folded upon it, and it cannot go through a smaller incision. But there are some very distinct advantages of PMMA IOL. One of them is that there is no chance of negative or positive dysphotopsia with these IOLs, which is a very significant problem nowadays with acrylic lenses. Like many of the time patient complains that temporarily I see this, that, a black edge kind of thing, which is not there with PMMA IOL. And I think the major contributing factor for that is, one is the square edge of acrylic IOL, which is there. Other is the angle, light angle, which is there in the acrylic IOL with the combination of refractive index. So one significant aspect is no positive or negative dysphotopsia. Then with acrylic IOL, the leading brand, if we discuss, so we all know that with Alcon IOLs, the advantages were that practically there were very, very little chance of after cataract development with these IOL. But the disadvantage is that a significant glistening is always incorporated with the Alcon IOL, Acrisoft material IOL, and that can be sometime very, very distressing to the patient. Their competitor brand J&J, or the initial earlier on Abbott and other names, so they did not have this kind of this feature, but they did not also have the yellow chromophore to prevent the AMD effect later on. And also the after cataract incidence was also not up to the Acrisoft one. So both the companies now, they have come up with their own modification to combat these problems. Alcon has now modified their material, and they are changing basically Acrisoft material to the Clarion material. All their future generation lenses are now based on the Clarion material, which is having very little glistening. They have reduced the yellow chromatophore also in that. Similarly, now J&J has inserted in some amount of chromatophore, and what they claim is that it does not filter the good part of blue wavelength. It generally filters only the violet, the more problematic part of blue wavelength. So these are the things actually. So I think with the good knowledge of these factors, we can have a very good correlation. When we talk about Bose and Lomb lenses, you also said about Envista lens. The basic problem with these lenses is that sometimes there is problem in folding of these lenses, and there can be micro cracks appearing in those lenses with some amount of IOL opacification also. So that was a basic drawback of Bose and Lomb material. Now they have improved upon their material, but still there can be some time problem with folding of these lenses. So I think with this background knowledge and incorporating that into the clinical working may help us, all of us. And I again reiterate, it was a very vast topic, and Dr. Has covered it in a very short period of time. So my compliment to him.
Okay, so we have some of our hot seat contestants that are students who have joined, who have spared their precious time to join in for the class. And I would like to briefly introduce these students. I would like to request them to please switch on their cameras so that we can directly view them. So we have Dr. Shubhankar and Dr. Pritisha Goswami from Nigrim's Medical College, Shillong. And we welcome you all to the class. And we also have Dr. Mohan Raj and Dr. Akshay. Dr. Akshay is a second year postgraduate at AIMS Patna, and as well as Dr. Mohan Raj and Dr. Praveen. Dr. Praveen is a junior resident in the Department of Ophthalmology at AIMS Jodhpur. So we welcome you all students to this class, and I hope you have gained some knowledge by the comprehensive lecture that Dr. Subhrangshu has given. Do you have any questions to ask from sir? If anybody has any questions, you can raise your hand and or you can ask us a question. Yes, Dr. Pritisha, you want to ask something? Please unmute yourself.
Good evening, ma'am. Good evening, sir. So, my question is, what is the relevance of the ABI number in the current IOLs that we implant? The ABI number, I'm not clear about that.
Dr. Subhrangshu, you have to unmute yourself.
Right. So basically, it's a measure. This is more of theory. It's actually a measure of the chromatic dispersion. So, the higher the ABI number, the lower is the chromatic dispersion and better optical clarity or the quality of vision. So this is more for theoretical knowledge. I mean, for the for writing answers or not. When we are looking at a particular lens in our day-to-day life, we are hardly aware of the ABI numbers. But of course, yes, these 4 or 5. When manufacturers they develop IOLs or when they are improving on the quality of IOLs, there are these 4 or 5 factors which they interplay upon to come up with better materials, and hence the significance of the ABI number. It itself is actually a very complex, it's got a mathematical model to it, which even I am not aware, but for all practical purposes, what we can remember is that higher ABI number of IOLs means lower chromatic dispersion, and hence a better optical clarity of the lenses.
Okay. Thank you, sir.
Thank you.
Better quality of vision is what we are targeting, and higher the ABI number, better is going to be the quality of vision because less chromatic aberration, right? Any other questions? Dr. Praveen, Dr. Mohan, you have any questions to ask, sir? Because it's going to be the other way around, then sir is going to ask you questions if you don't ask.
Or maybe the other way around, we would like to hear more from Dr. Sharma, because most of the things that I spoke on, I could not get these lenses in my time of work. Maybe sir has used more of these.
So, sir, you'll have to unmute yourself.
Yeah.
Dr. Mukesh, yeah.
Yeah, actually, this is one advantage of your gray hair, which I have colored them up, but you have got more experience and you have used, like I have used, I think most available lenses from very beginning, like all PMMA kind of lenses, then the J loop, C loop lenses, and first generation foldable lenses from silicone lenses to acrylic lenses. So it's an ongoing journey. And in initial lenses, they had some problems. Nowadays, whatever lenses we are having, most leading manufacturers, they are providing us with very good quality lenses. And hardly we face significant problems with these lenses. I think Dr. Subhrangshu has covered many of the things, and some of the points which I wanted to tell, so I have already told. So if there is any clarification which somebody wants, we can always tell that.
Okay. So let's ask the students. Dr. Praveen or Dr. Mohan, would you like to let us know what are the different type of IOLs that you use in your hospital? Can you unmute yourself?
PM,
Yes. You're using PMMA lenses?
acrylic hydrophilic, acrylic hydrophobic lens.
Okay. So if you've been given a box of an IOL, how do you identify whether it is hydrophobic or hydrophilic? Anyone would like to answer? Dr. Pratisha, would you like to answer? Dr. Praveen?
Yes, ma'am. Ma'am, ma'am, it will be mentioned about the water content.
No, you
And
don't have the cover box. You don't have the cover box mentioning you whether it's hydrophobic or philic. You just have
okay,
the IOL and it's in a seal pack, and you have to tell us whether it's hydrophilic or hydrophobic.
okay, ma'am.
The sister
There's
has
no.
has it on the table, and can you can you identify her based on its packaging? Yes, Mukesh sir, I think you can give
See,
some
one
some
very
light.
simple thumb rule is that most hydrophilic lenses, they come into a liquid, aqueous kind of solution basically. Though it's not 100% true, some of the hydrophobic lenses, they also come with water container. But most all hydrophilic lenses, they have to come in a water filled or aqueous filled bottle or vial or a pouch, whatever it is. They cannot be dry, because if they are dry, the material itself will lose its property. While hydrophobic lenses, most of them, they come dry, but some of them, they also come as a water filled container, because in some of the materials, they require water to be filled in for their pliability. Otherwise, it becomes very, very hard to fold. But I think that's what she meant when she asked for that.
So
If
next time when the
IOL
sister is
water,
loading the IOL, just be
yeah.
very careful and watch what kind of an IOL and what packaging it is and what is she opening for you, so that you know what type of IOL you are actually implanting. Sir, any more questions that you want to ask the residents that the residents should know
No,
as I take
yeah, actually, my one advice is that always read the leaflet of IOL which you are implanting or you are dealing with. So it's a very good idea, and you get to know about many things. So it's a very, very good habit to read leaflet of anything which you are using, especially the IOL. See, if I ask you a question, what are the contraindication of intraocular lens uses? So any of you would be telling me about them? Contraindication of intraocular lens use.
Anyone wants to answer that?
This question may be asked in your PG exam also by examiner like me or any other person, because and you will get this information in the leaflet, IOL leaflet, which is there inside. So it's a very interesting thing. So contraindications, there are various. One of them is anatomically abnormal eye, very small eye, small microphthalmic eye. You would not like to use IOL inside in those eyes. And the older generation books, they say that inflamed eye means history of uveitis. You should not be using that. NVI is a contraindication for IOL. In older standard, if when you talk about standard contraindication, then NVI used to be one of the contraindications. But hardly nowadays, like we do not follow them as such. But yes, very small microphthalmic or IOL still is a contraindication.
Even in pediatric cataract, usually kids who are less than 1 year old, we usually don't implant IOL. Although there are recent studies coming up where they're implanting IOLs even in 3 months and 6 month old. But the conventional thought was that in less than 1 year old kids, we usually did not implant IOLs.
Especially when it is bilateral.
Yeah. Bilateral cataracts.
Yeah. So it's a very good habit to read leaflets actually. So tomorrow when you go to your OR, just check the leaflet of IOL which are being used in your OR. You will get to know about many things.
Dr. Akshay, anything that you want to ask?
Ma'am, just want to know about the design. Just about the design of toric lenses.
I think toric and multifocal are going to be covered in the next class, when in the advanced IOLs and premium IOLs are going to be discussed. So let's not touch that topic, as it itself is a long class. So that we'll be discussing in the next class on next Wednesday. Okay, sir. So I think we have had a comprehensive class, and I would like to thank Dr. Mukesh sir for sparing his valuable time for the class, and Dr. Subhrangshu for this comprehensive lecture, and all the students who have had this taken out time from their busy schedules, from their duties, to spare time for this class in the evening as well. Thank you, everybody.
Thank you.
And again, I would also like to invite all the students who have connected to us with this class today, that we have the physical iFocus that is going to be organized, that Dr. Santosh is doing a wonderful job for almost a decade now, conducting this physical iFocus class. And this year, the class is going to be conducted in Hyderabad itself. And it's a pre-registration that is required, and 500 students can register. So if you're interested, you can please register yourself for the physical iFocus that is to be conducted from 9th to 11th in the month of June in Hyderabad. Okay. With that, I would like to end this class of iFocus. Thank you, everyone, for your time. Thank you.
Thank you.
Thank you. Good night.
Bye-bye. Good night.
Good night.